What is secondary hyperaldosteronism in one sentence? It's a condition where too much aldosterone is present in the body due to RAAS overactivity, meaning with elevated renin levels. It causes symptoms like hypertension, hypokalemia, and metabolic alkalosis. But in contrast to primary hyperaldosteronism, secondary hyperaldosteronism always involves RAAS overactivity, while primary hyperaldosteronism is characterized by autonomous aldosterone production and renin would be suppressed. So with this definition in mind, let's answer the question, how do symptoms develop in hyperaldosteronism? So here's a brief review in 1 minute. Aldosterone is part of the RAAS, a system for blood pressure regulation. The kidney measures kidney perfusion, meaning blood flow to the kidney, and when this drops, the hormone renin is secreted. A cascade in the blood is set in motion, and among other things, angiotensin II levels rise, which ultimately stimulates aldosterone production. Aldosterone is also a hormone like renin, but it acts in the cells of the distal tubulus, where it increases the amount of certain channels and pumps. The ENaC is a sodium channel. ROM-K is a potassium channel, and then there's the sodium-potassium pump. So what are the effects of aldosterone? Incoming sodium from the distal tubulus is reabsorbed more and released into the blood. It passively pulls chloride and water with it, thereby increasing blood volume and then blood pressure. However, another ion must be released into the urine for electroneutrality. That's why potassium is excreted. This already explains why with high levels of aldosterone, as in secondary hyperaldosteronism, hypertension and hypokalemia might occur. Hypertension doesn't always occur, and secondary hyperaldosteronism is divided into hypertensive and normotensive forms. But more on that and why this is in just a moment. Additionally, in so-called intercalated type A cells in the distal nephron, the number of proton pumps is increased, making the urine more acidic and the blood more alkalotic in return. This explains why metabolic alkalosis may be present in this condition. So how does the RAAS overactivity occur? Anything that chronically can reduce kidney perfusion may lead to a RAAS overactivity. One cause can be local at the renal arteries. Renal artery stenosis, for example, can develop through arteriosclerosis in patients with cardiovascular risk factors or in young people with collagen disorders like Ehlers-Danlos syndrome, and then they can often be bilaterally. No matter how high the blood pressure is, the blood loses pressure after the stenosis, and this leads to less kidney perfusion distal to the stenosis, and the kidney thinks, blood pressure is too low, and it chronically increases the RAAS activity. The systemic blood pressure may still be high. This finding can be detected using duplex ultrasound. Another cause for RAAS activation is when blood pressure is truly too low, so generally speaking too low. Two causes are distinguished here. First, when there is too little volume in the body due to true volume depletion, and there is too little fluid in the blood left to generate enough blood pressure. So this is why hypertension can be absent and patients may have normal blood pressure or hypotensive states, even though aldosterone is high. One typical example for this might be the chronic or long-term use of diuretics, since they chronically reduce the volume and electrolytes in the body. And interestingly, there are so-called tubular diseases, so congenital disorders in the tubal system that mimic the use of loop and thiazide diuretics. These are Bartter syndrome and Gitelman syndrome. Ion channels are defective in these conditions, and there's also a loss of ions and water as with diuretics. And these are typically normotensive because the body has found compensatory mechanisms early on. Let's move to a similar cause. There are conditions where there's actually enough volume or even too much in the body, but intravascularly, meaning inside the vessels, the blood is missing. In diseases like chronic heart failure, cirrhosis or kidney failure, fluid can either accumulate in the abdomen called ascites, in the legs called leg edema, or in the lungs causing dyspnea. And this concept is called reduced effective arterial blood volume, EABV. The blood doesn't arrive where it should be. This also leads to an increased RAAS activation because the kidney thinks blood pressure isn't high enough. A vicious cycle may develop because the more aldosterone retains more sodium and fluid in the body, it worsens edema and ascites and also reduces the EABV, so the effective arterial blood flowing into the kidneys. The RAAS remains active, and the maximum version of this in liver cirrhosis is called hepatorenal syndrome, where the kidney clamps off its own perfusion through RAAS overactivity, since angiotensin is also a vasoconstrictor in the kidney. Another cause is chronic kidney disease, or CKD. The causes are diverse and the mechanisms not fully understood. In CKD, nephron loss leads to compensatory glomerular hypertension and proteinuria. Proteinuria, so protein in the urine, activates inflammatory signals, and they lead to an upregulation of the RAAS locally and systemically. The last cause of RAAS overactivity is a reninoma, so a kidney tumor that produces the hormone renin. This is very, very rare, but it might occur more often in young women, studies have shown. And a very markedly elevated ratio of renin to aldosterone, so very high levels of renin, in contrast to rather mildly elevated levels of aldosterone, can be indicative. And a CT scan may help to show a tumor in most cases. Let's summarize today's topic. First, the key difference from primary hyperaldosteronism is in plasma concentrations. In primary hyperaldosteronism, aldosterone is high and renin is suppressed. In secondary hyperaldosteronism, both aldosterone and renin are elevated. However, both can cause hypertension, hypokalemia, and metabolic alkalosis. But these effects don't all have to be present simultaneously, so there might only be hypertension or hypokalemia, or maybe only metabolic alkalosis. Second, for example, blood pressure can also be normal or even low in diuretic-associated hyperaldosteronism, or in conditions with tube volume loss like Bartter and Gitelman syndrome. Third, renal artery stenosis causes secondary hyperaldosteronism through reduced kidney perfusion distal to the stenosis. This can occur in elderly people from atherosclerosis or in young patients due to fibromuscular dysplasia. Fourth, conditions with reduced effective arterial blood volume, such as heart failure, cirrhosis, or nephrotic syndrome, activate the RAAS despite total body volume overload, creating a vicious cycle of fluid retention. And fifth, chronic kidney disease can cause secondary hyperaldosteronism through complex mechanisms involving nephron loss, proteinuria, and inflammation. I hope this video was helpful to you. Consider subscribing, and I'll see you in the next video.